Welcome. Today, we're diving into a rare and serious eye condition called malignant glaucoma, also known as aqueous misdirection syndrome. This is a complex type of glaucoma, distinct from the more common forms, and it requires specialized understanding and treatment. We will explore what causes it, how it affects the eye, and what can be done to manage it. The exact cause of malignant glaucoma remains somewhat elusive, but it's generally understood to be related to a misdirection of aqueous humor. Instead of flowing through its normal channels to drain from the eye, the aqueous humor, the clear fluid that nourishes the eye, gets diverted posteriorly, behind the lens and into the vitreous cavity. This misdirection can be triggered by various factors including, but not limited to, certain types of glaucoma surgery, particularly those involving peripheral idotomy or iridectomy. It can also occur spontaneously, especially in eyes with predisposing anatomical features, like a narrow angle or a small eye size. Let's delve into the pathophysiology. In malignant glaucoma, the aqueous humor abnormally flows behind the lens, accumulating in the vitreous cavity. This accumulation pushes the lens, iris diaphragm forward, shallowing the anterior chamber, which is the space between the cornea and the iris. The forward movement of the lens obstructs the trabecular meshwork, the eye's natural drainage system, leading to a sudden and significant increase in intraocular pressure, or IOP. The posterior pressure also causes compression of the choroid. Ultimately, this elevated IOP damages the optic nerve, the vital link between the eye and the brain, resulting in progressive vision loss if left untreated. Understanding this mechanism is crucial for effective diagnosis and management. Malignant glaucoma is a relatively rare condition. Precise epidemiological data is limited, but it is estimated to occur in a small percentage of patients following glaucoma surgery, especially angle closure glaucoma procedures. Individuals with pre-existing narrow angles, small eyes, nanophthalmos, or a history of certain glaucoma medications may be at a higher risk. While it can occur in individuals of any age, it is more frequently observed in older adults who have undergone glaucoma surgery. The signs and symptoms of malignant glaucoma can be quite alarming and typically develop rapidly. Key indicators include a sudden and dramatic increase in intraocular pressure, often accompanied by eye pain and blurred vision. A shallowing of the anterior chamber is almost invariably present. Patients may also experience headache, nausea, and vomiting due to the elevated pressure. Importantly, these symptoms can mimic other types of glaucoma, making accurate and timely diagnosis critical. Diagnosing malignant glaucoma can be challenging as it requires differentiation from other forms of angle closure glaucoma. A thorough eye examination, including gonioscopy to assess the angle of the anterior chamber, is essential. Ultrasound biomicroscopy, or UBM, is a very helpful imaging technique that allows the doctor to visualize the structures behind the iris and lens, confirming the posterior misdirection of aqueous humor. Optical coherence tomography, or OCT, of the anterior segment can also be utilized to assess the angle and measure the anterior chamber depth. These imaging modalities help rule out other causes of elevated intraocular pressure and establish the diagnosis of malignant glaucoma. While there aren't distinct types of malignant glaucoma in the traditional sense, it can be categorized based on its onset, either as occurring after surgery, a post-operative, or occurring without prior surgical intervention, as spontaneous. Recognizing whether it is post-operative or spontaneous can guide the initial approach to treatment. Treatment for malignant glaucoma aims to redirect the flow of aqueous humor and lower intraocular pressure. Medical management often involves cycloplegic agents, such as atropine, to relax the ciliary muscle and pull the lens posteriorly. Aqueous suppressants, like beta-blocker alpha-adrenergic agonists, are used to reduce aqueous production. If medical treatment fails, surgical intervention becomes necessary. Options include laser iridotomy to improve fluid flow, Enbro-Wig laser hyalodotomy to break the anterior hyaloid face, and vitrectomy, a surgical procedure to remove some of the vitreous gel, creating space and allowing the aqueous to flow correctly. In some cases, lens extraction may also be considered. The specific treatment approach is tailored to each individual case. Unfortunately, there is no specific method for prevention. In patients with narrow angles undergoing glaucoma surgery, careful pre-operative assessment and consideration of prophylactic measures, such as laser peripheral iridotomy, may help reduce the risk. However, even with meticulous surgical technique, malignant glaucoma can still occur. The prognosis for malignant glaucoma can vary. With early diagnosis and prompt treatment, the condition can often be managed successfully, preserving vision. However, delayed diagnosis or inadequate treatment can lead to reversible optic nerve damage and significant vision loss. Recent research is focused on improving diagnostic techniques, refining surgical approaches, and exploring new medical therapies to optimize outcomes for patients with this challenging condition. continued research offers hope for more effective treatments and improved visual outcomes in the future.